So continuing with our case discussion series, now we are going to talk about a patient with a neck swelling, right? Now, you must have seen in all these case discussions which I've discussed you, I don't want to tell you the diagnosis upfront, which is why I'm saying a case of an abdominal lump, a case of a neck swelling, because I want you to understand what are the key words in history, key words in examination, and how do we work up these patients. Because in real life, that's what's going to help you treat these patients. And also, if you're asked clinical scenarios or clinical vignettes in the next exam, that is what will help you in making the diagnosis. Okay. So we have a patient with a neck swelling. Let's look at the history of this patient. There's a 34-year-old housewife who has come with a swelling in the midline of the neck. So as soon as you know it's a swelling in the midline of the neck, the first thing you start thinking about is a thyroid swelling. Now the swelling it's been there since 4 years, so there is a prolonged history. There is a prolonged history which is there. The swelling is insidious in onset, gradually progressive and painless, right? There is no history suggestive of pressure symptoms, okay? No history suggestive of pressure symptoms. So either you can enlist all the pressure symptoms, or a wise student is just going to say no history suggestive of pressure symptoms, and then let the examiner ask you what are the pressure symptoms which you asked for. So that would be an additional question for you. So what would be the pressure symptoms which we will ask for? We are going to ask for hoarseness of voice, dyspnea, dysphagia. These are the pressure symptoms which we need to ask for in any thyroid swelling if it's pressing on the recurrent laryngeal nerve, the trachea or the esophagus. There's no history suggestive of hypo or hyperthyroidism. Again, let the examiner ask you what are the features of hypo and hyperthyroidism. This I've covered in great detail in the module and you can go through them. So you should know the features of hypo and hyperthyroidism. There are no other swellings in the neck. This is also important. Why is this negative history important? To look for lymph nodes. If there are any lymph nodes in the neck, so this is also a history which you should elicit in these patients. There is no history of weight loss, loss of appetite, bone pains, headache, seizures, dyspnea and jaundice. So basically no history suggestive of metastasis, right? So you can even say this and let the examiner ask you. Patient has no comorbid conditions. A good line to add here would be the patient is not on any medications. The patient is not on any medications, because you know that there are certain medications which can be goitrogenic as well. So not on any medications. The past history is non-contributory. Family history, there is no family history of malignancy, especially thyroid cancers. Regular periods are there. She's a P2L2 menarche at 13 years of age. The personal history, the bowel bladder habits are normal, sleep habits are normal, no addictions. In the dietary history, you can mention that the patient takes a balanced diet, and if there is excessive consumption of vegetables of the Brassicaceae family, you know, if she's consuming cabbage excessively or not, so that you can mention, you can take that history and at least mention so that the examiner knows that you're aware that if the Brassicaceae family vegetables are consumed in excess, they can also give rise to a goiter. Okay. So these are the points in history, and as we've been doing in all the case scenarios after history, let's summarize the case and let's discuss what can be the various possibilities. So what we have here is a 34-year-old lady, and she has a midline neck swelling. Okay, which has been there since 4 years, gradually increasing in size to the current size. There are no features of hypo or hyper, and there are no features of no compressive symptoms. There are no compressive symptoms as well. Okay. So just based on the history of 4 years, we are probably looking at a benign condition. Also because there are no features of compression and no metastasis in this patient. Okay. But let's look at the examination and see if our diagnosis changes. So she's a middle-aged, moderately built female. Vitals, you have to take the vitals, especially in a thyroid case. You have to take a pulse. Let me tell you a scenario where there was a patient in hyperthyroidism, and I was a senior resident. There was the undergraduate exam going on, and the student very confidently presented a thyroid case, but missed out that the patient was in atrial fibrillation. And just because of that, the examiner failed the student. So don't make this mistake. Take proper vitals, normal rhythm is there, no irregular pulse. Take the BP, nutritional status, hydration status, the general physical examination is normal. You should definitely comment on pedal edema, because in patients, you can have pretibial myxedema as well in patients with hyperthyroidism if they have Graves' disease. So definitely comment about pedal edema also. Don't miss that out. Let's look at the video of this patient of the neck swelling, and then let me describe the swelling for you. So you can see here, when the patient there is movement on deglutition and the swelling is restricted to the right side only, right? Just to the right of the midline. Just by examination, you can see that the swelling is restricted to the right of the midline. You can't see any swelling on the left side and deglutition. And when the patient is swallowing up, even on inspection, you can very well make out the lower limit of the swelling. All these are important points. I'll elaborate on them when I describe the examination. So the patient you have to say that you examine the patient standing in front of the patient. The palpation was done from behind as well. So this you should mention when you start your examination. Another good thing to say when you're talking about thyroid examination, you should say that you were at the same eye level as the patient. That is also very important. And I've highlighted this especially when we talk about eye signs. If you remember the first module on thyroid where I've demonstrated the eye signs on somebody, I told you that eye signs should always be elicited when you're standing at the same eye level as the patient. Eye signs should always be elicited if you're standing at the same eye level as the patient. If the patient is sitting and you are standing and you're doing the eye signs, you've already failed for me. So this patient had a 4 into 3 centimeter swelling to the right of the midline of neck, right? On inspection, you could make out there is a swelling approximately 4 into 3 centimeters right of the midline of the neck, moving with deglutition, not moving with protrusion of tongue. To demonstrate protrusion of tongue, please remember, if you're demonstrating protrusion of tongue, please support the head with one hand, right? And then you demonstrate protrusion of tongue. If you don't support the head, then the patient is going to move the neck and the head, and that can also give you a false sense of the swelling moving. So please remember this point as well. Now the swelling involves the right lobe of the thyroid. Margins are well defined. It is non-tender. It is multinodular, and the lower limit is palpable. So this is important. It is a multinodular swelling, non-tender, firm in consistency. Lower limit palpable means there is no retrosternal extension. No retrosternal extension. If there is retrosternal extension, the lower limit will not be palpable. Please remember this. So this you have to say. Another very important thing which you have to say, the rest of the thyroid is not palpable, right? Rest of the thyroid is not palpable. That means the isthmus and the left lobe are not palpable. This is also very important because this is then a solitary thyroid nodule. There is only this nodule which is there on the right side. The rest of the gland is not palpable. Okay. Very important that you comment whether the trachea is central or not. Sometimes very large goiters can push the trachea. Bilateral carotid pulse is palpable. This also you should comment. Cocker sign, if it's a very big thyroid swelling, Cocker sign. Cocker sign is when with one hand you support the trachea and the other hand you push the swelling. One hand you support the trachea, other hand you push the swelling. Sometimes the swelling can press on the trachea and this can trigger a stridor or dyspnea, and that is a positive Cocker sign if the trachea is getting compressed. Here the Cocker sign wasn't positive. It is very important for you to comment that there are no other swellings in the neck. So this means that we've commented about lymph nodes. No lymph nodes are palpable in the neck. The cervical spine examination, you should comment on cervical spine. Big thyroid swellings can sometimes affect the movement of the cervical spine as well. The patient has no tremors. Eye signs you should elicit. Even if the patient is euthyroid, elicit the eye signs. I've already shown you how to do the eye signs in the first module on thyroid. And the systemic examination is within normal limits. I've told you to comment on pedal edema. It is very important in a thyroid case. Okay. Now, before we go on to the impression, you should know that Pizzolo's method. Pizzolo's method is another method to look at a thyroid swelling, where you ask the patient to press his head against the hands, press the occiput against his hands, and this would make the swelling more tense and more prominent, and you can examine from the front, right? This is Pizzolo's method. Lahey's method is when you examine from the front and gland is pushed from one side and you examine on the other side. And Kreil's method is when you ask the patient to swallow and you palpate with a thumb. So all these are just methods. These are more relevant for your MCQ exam. There was one question asked in the AIIMS exam 2 years back, which is why I'm mentioning. Otherwise, if you get a thyroid case, mention all the points which I've covered. That should be good enough. You should know how to elicit the eye signs. I've already shown in the image and thyroid 1 module. I've demonstrated how to elicit the eye signs. So what will be our impression of this case? The impression is going to be a 34-year-old lady with a multinodular goiter involving the right lobe of thyroid, because only the right lobe of thyroid was enlarged and there were multiple nodules there. If there was a smooth surface, just a diffuse enlargement of the right lobe, then we would have called it a solitary thyroid nodule. But because there are multiple nodules, it is a multinodular goiter involving the right lobe of thyroid. Patient is clinically euthyroid in sinus rhythm without any compressive symptoms. So all these points have to be included when you are summarizing a case of thyroid: compressive symptoms, euthyroid, and whether it is a solitary thyroid nodule or a multinodular goiter. So that is our impression. Now, what do you think? It's a malignant swelling or a benign swelling? It appears to be a benign swelling. And what are the points in history which support it? The points in history are long-standing swelling, a long-standing swelling which is slow growing, no compressive features, no compressive symptoms, no metastasis, right? On examination, no lymph nodes are there, That is another sign that it is unlikely to be malignant given the size of the swelling. So these are the points which tell me that it's a benign swelling rather than a malignant swelling. So most probably it will be a multinodular goiter. Now, how do we proceed in this patient? So up till now we've been discussing investigations to confirm the diagnosis, to support the diagnosis, and to treat the patient. You need to understand that the first investigation which we always do in a thyroid case, and this is a very common MCQ also, the first investigation which you will do in these patients is the thyroid function test. And thyroid function test is what is going to tell you whether the patient is actually euthyroid or there is hypo or hyperthyroidism. Once we know that the patient is, if we know that the patient is eu or hypothyroid, when we know that the patient is eu or hypothyroid, we can do an ultrasound of the neck with USG guided FNAC. Now, what all information with an ultrasound of the neck tell you? This is what the examiner is going to ask you. So ultrasound of the neck will tell us if both lobes are involved, or as per clinical examination only the right lobe is involved and the left lobe is normal. Sometimes it can happen that the left lobe might not be palpable, but on ultrasound small nodularities might be seen there. So you'll look for both the lobes. You will see if the swelling is hypoechoic or hyperechoic. Hypoechoic more likely to be malignant. And if there is increased vascularity or not, again, if there is increased vascularity, it can be a sign of malignancy. You will also comment about the lymph nodes, if lymph nodes are present in the neck or not. I've already told you what are the features of a benign lymph node and a malignant lymph node. This I've already covered in the module. Benign lymph nodes are going to have a preserved fatty hilum and they will be kidney shaped. Now, why am I doing an ultrasound guided FNAC along with this? Because this increases the yield of the FNAC. I will know where to do the FNAC and I'm likely to get a better representative sample rather than just doing a blind FNAC. You know, FNAC is fine needle aspiration cytology and 23 to 30 gauge needle will be used for this. So this is how we are going to work up our patient. First do thyroid function test, then do an ultrasound and an ultrasound guided FNAC, and this is what you're going to say because it is going to increase the yield. Now, in this case, the ultrasound guided FNAC revealed it to be a colloid goiter. A colloid goiter. Okay. So, how do we proceed in this patient? Now, we know that there is a colloid goiter only involving the right lobe. The left lobe is normal. So, the management is going to be surgery in this patient. And what surgery will you do? You know, the minimum surgery for thyroid, I've told you many times, is hemithyroidectomy. Hemithyroidectomy is, you know, it is removal of one lobe plus the isthmus. So, here you will end up removing the right lobe and the isthmus. Please don't use the term lobectomy, right? Use the term hemithyroidectomy. Hemithyroidectomy is removal of one lobe and the isthmus, okay? So this is how we proceed in a patient with thyroid cancer. So this is how we proceed in a patient with a thyroid swelling. I've highlighted the points in history. If you get a midline neck swelling, how to go about the examination. The eye signs are very important. They are given in thyroid 1 module. And how do we work up the case? This will not only help you for your college exams, but this workup is also commonly asked in the MCQ exam. If you have any doubts regarding this case, you can always send me a message on my social media handles or ask me on the Marrolinks Facebook group. My social media handle on Instagram is left-handed surgeon.